Hello and welcome to our special coverage on COVID-19, where we bring you all the analysis, the update, and also give you the platform to share your views on coronavirus with us. So, as you well know, globally we have crossed 3 million confirmed cases. Yes, that is what coronavirus is doing. Several people have died. Now, back here in Ghana, we stand at 1,671. We'll be delving deeper into this, give you a breakdown, and also look at other issues as well. My name is Fremedu Name. I will be introducing my guest to you shortly, and we will have a conversation. After this break, we'll do so. Don't go away. You're welcome back. This is our special coverage on coronavirus. You may be reaching us via Citi FM 97.3 or watching us on Citi TV. You probably might also even be watching us on Facebook as well. My guest already seated. I have here with me Godfred Akoto-Boafo. He is head of current affairs and a team member of the Citi Breakfast Show. Godfred.
Always a pleasure, Frema.
Right, and I also have here with me Salom Adonu, who is counsel and also head of features and articles, Citi FM and Citi TV counsel. You're welcome.
Thank you very much.
Right, so Godfred, we're going to be going straight, to our global figures. We have passed 3 million. That sounds a bit scary, but we are still fighting on. Give us the breakdown.
Yeah, it's scary, but much better than it was a few weeks ago. Generally, there have been slowdowns across the world. But as we also know, this disease has the tendency to slow and then speed up.
Yes.
So let me just give you the numbers, and then I'll give you a few global headlines as well, and then Salom can do the Africa track numbers for you. So globally, as you said, you are right. We are at 3,139,415 confirmed cases globally. Total deaths globally stand at 218,456, and I can give you a few country specifics. The United States at the moment continues to
be in the lead.
The most recorded cases. They have 1,013,168 cases, 58,000 deaths in the United States alone on this. New York State has 17,682 of these deaths, but in the US they are also testing significantly. Tests are almost now at 6 million. They're running almost 6 million tests in the United States. If I take you to Spain, Spain at the moment 236,889 confirmed cases, 24,275 deaths. Recoveries are at 132,929. Let me take you to the United Kingdom, because the United Kingdom has sped up quite significantly. 162,350 confirmed cases, 813 recoveries, and 21,745 deaths. Now, let me just add Italy and Germany, and I'll give you some global headlines as well. Italy has confirmed 201,505 cases, 27,359 deaths overall, and finally Germany, 160,059 confirmed total cases. Total deaths stand at 6,314. Let me see their recoveries. Their recoveries at 120,400. Let me give you a few global headlines, and then I will hand over to Salom to do the African numbers. So Germany, FEMA is advising against international travel until at least June 14.
They seem to be doing very well in handling coronavirus.
Yes, but they are setting very tight facing down rules, I would say. So Germany says that all international trips are being advised against until at least June 14.
Wow.
And this according to the country's foreign minister, Heiko Maas. He says that he told reporters that the country could not advise travel without worries, and that Germany is coordinating with its European neighbors on the global travel warning. Let me see what other interesting developments have emerged that I can give to you.
Yeah.
Well, Russian Prime Minister just a few hours ago says that it's also impossible to give an exact date when they are going to reopen their borders. As you know, they are also being lashed quite heavily, and they barred entry to foreigners from April 30 to halt the spread. So they just recently started from tomorrow, basically. They will be doing that. Also, a couple of headlines. Let me take you to Asia, where Beijing is lowering the coronavirus emergency response from the highest level. And as you know, the Chinese, because of what they've been able to do, they are now moving the country from the highest designation of level 1 to level 2. From the level 2 to level 3, that means they are completely out of the woods from there. And then let me give you a bit from Africa. Quite a lot happening, Frema. Now in Africa, there is anger in Tanzania. As you know, President John Magufuli has been doing things a bit differently. And so now the Prime Minister today says the country has 480 cases, but social media says they don't believe the numbers because in Tanzania the updates don't come. They don't know when testing is happening. They basically don't believe the system. Yes, you are there every 2 weeks. They come and give you some random number, and so they are quite upset in Tanzania over that one. And Frema, you will not believe this particular headline. In Uganda, members of parliament decided to pay themselves $2.5 million as to go and do coronavirus education. So every member of parliament was going to get $5,000 as a fee to go and educate people in their communities. Well, the president heard of this, our good friend M7, Yoweri Museveni, and he spoke to the Speaker of Parliament and told the Speaker of Parliament to tell the MPs that they should go and pay that money to district assemblies, rather, for the district assemblies to carry out the education, and that if you're an MP and you've already received the money and you've chopped the money, find a way of paying back that money to the district assemblies, or you and him will have issues. And this is
did they tell us how they're equipping their district assemblies rather in this
Yes, they had put that in place. So they were expecting that he was expecting the money would rather go there, and not that parliamentarians would go and agree to this money.
They sat in parliament and agreed to
$2.5 million. Yes, each parliamentarian got $5,000. And a pretty worrying case from Kenya, and I'm sure we'll go into details because today we are doing a bit of comparative analysis. Kenya's research center is running out of test kits. Very, very important. The Kenyan Medical Research Institute, KEMRI, says that he has depleted its supplies of coronavirus screening and test kits, and this was in a report that was tabled before their Senate committee, and they are saying that they need $7.3 million to restock reagents and other materials used for testing. So far to date, as we know, Kenya has recorded 14 deaths and 373 cases. So these are the global headlines I'll give you. Salam.
Right, so Salam, let's look at Africa, South Africa, Egypt, Nigeria. I mean, let's leave Ghana out because we will come to Ghana properly. So let's look at these other places.
Yeah, so Egypt tops the continent with 5,042 cases, recorded quite a number of deaths, 359, and they have tested 50,000 times. If you recall, sometime last week I was saying that they were at 55,000 for a long time. It appears they've now updated their numbers. So they've tested 90,000 times and they've recorded a little about 5,000 cases. South Africa has 4,996, almost 5,000 cases. 93 people lost their lives to the disease. 185,497 tests. They've tested the most in Africa. Morocco, in terms of everything, individual tests. Morocco has 4,289 cases, 167 people, 437 deaths, and they've tested just 6,500. And this is the country with the highest, death toll, or the numbers, as far as Africa is concerned, 437. And interestingly, they've only tested 6,500 times. Cameroon comes in number 5 as having recorded 1,806 cases, 59 deaths, number of tests not known. Ghana comes in as number 6. Ghana was at number 11, came to number 10, number 8. Ghana, because of how our numbers have gone up, because of our enhanced testing, etc. Ghana is at number 6 with 1,671 cases, 16 deaths, tested some 100,000 times, or a little over that. Nigeria comes in with 1,532 cases, 44 deaths, tested 12,828 times. Guinea comes in number 8 with 1,240 cases, 7 deaths or so. Ivory Coast with 1,183 cases, 14 deaths. Djibouti, 1,077 cases, 2 deaths, and they've tested 12,985 times. Tunisia has 975 cases, 40 deaths, and their test numbers not known. Senegal recording 823 cases, 9 deaths, and Senegal has been testing a lot using the RDTs. And Niger comes in with 709 with 31 deaths, and then 5,116 tests. So basically, that is how the figures or the chart looks like for Africa. And a number of interesting things there. When you look at Egypt, for example, the WHO has said in the past few days that Egypt needs to improve upon its testing, because there appears to be a lot more people in that country, but the test numbers do not appear to be adequate. Now they are 90,000 tests. I think the WHO is expecting them to do way better than this.
Do they have what it takes?
Well, Egypt is one of the most developed countries in Africa, despite the fact that they've had some political instability arising from the Arab Springs, etc. I think they stand in a better place economically than a lot of countries in Africa who are doing some good work, like Ghana, for example. So they should be able to test better. And they have quite some good relationship with America. America deals with them a lot in terms of defense.
But
and
America
I'm sure
themselves
but they are helping people. America has helped Ghana, and they are helping other people. So if indeed Egypt requires some assistance to do more testing, I'm not sure America and the other countries will look will say nothing to them. So they need to rack up their testing. That's what the WHO is saying. And when you look at Morocco, an interesting thing happening in Morocco is that they have a number of prisoners now testing positive for the virus. Hundreds of Moroccan inmates test positive for the virus, and some 313 coronavirus cases have been reported in that country's jails following a mass testing for the prisoners in that area. We may go a bit into that as the show grows. And also, South Africa is saying that it has increased its tests, and indeed it shows in the figures, but their mortality rate remains at 1.9%. So they appear to be saying that though we are increasing the number of tests we are doing, and maybe even the number of cases, mortality rate is not increasing as a number of cases. So they think they are doing some good job in terms of managing the cases there. So basically, that's how a quick run through the African continent looks like.
But we still have some African countries who have recorded 0 cases.
Yes, I think, is it Lesotho?
So Lesotho.
Yes, and
Comoros
Island, yes.
Yeah.
You know, we don't know whether they have been doing a lot of testing and so not finding anything, because Lesotho is embedded in South Africa.
Yeah.
And Lesotho, to a large extent, depends on South Africa for a lot of things. I'm not sure Lesotho, I don't have a now, but I'm not sure they shut their borders, you know, way ahead of time. So it could be an issue of capacity to test well and test more, but it's certainly something that requires some detailed attention. So Comoros, yes, economical, I'm not sure how their testing is going, but Lesotho appears like an interesting case. And indeed, one other country across the globe, that is North Korea. We've not heard anything on North Korea as far as I'm concerned regarding COVID, you know. And it's North Korea is particularly interesting because of their relationship with China. North Korea, they are very good friends with China, and if China recorded quite a number of cases, and the way they relate, quite some good transportation in between the two countries, you should expect transfer of people or movement of people here and there. But we've not heard anything from North Korea. North Korea is an interesting case because of how that country is being managed and the autocratic nature, the way they kill communication, suppress free speech, censor a lot of things. So it will be interesting to know what the case is there, whether indeed coronavirus is in North Korea or not, and if it's how they're doing it. Is it that they've deliberately kept the information away from the world, or they are dealing with other weightier matters? As in the past few days, some interesting news has been coming from there.
Yeah. Right, so Godfred, let's come to Ghana.
Okay.
Currently, we stand at 1,671, and if you're looking at our testing capabilities, it appears that it might have played a role in we recording high figures. Or we are still recording a lot of cases and we should be worried about it?
Well, when it comes to, I'm looking at the Citi newsroom.com/coronavirus, our dashboard, which basically is an integrated platform to get all the numbers. And
so we have the figures on the screen.
Yes, so 1,671 cases. Total active cases are 1,467. Recoveries 188. The biggest problem, the biggest problem for us, from looking at all that we have done, and we have done a lot of good work, is still the slow turnaround in testing time. In fact, today we had the Bono Ahafo branch of the Ghana Medical Association asking that turnaround time go up because there are just too many delays in between, and so they even made a request that the Medical Research Center at Kentampo perhaps be upgraded so that they don't have to go all the way to KCCR. We've had instances where people have been tested for a month and are not getting their results back. We know several people who fall in that category, and so you end up always asking yourself, what is the incidence rate on a daily level, because there's a constant backlog. We do expect our numbers to go up. At the moment, it looks like on our case management side, a lot of mild cases as they keep on reporting.
But what is not getting well?
But because we go through a very long recovery phase, as the WHO has set in. I don't know what other criteria other countries have set, because, for instance, I look at Senegal and they have a really good graph when you look at recoveries. But I don't know what the criteria is. It has not yet been made. I don't know if it's the same one that we are following here as to what they call a recovery. But again, I look at, for instance, the president spoke on Sunday. We had 10 or so cases. One was added in terms of deaths. As at Saturday, when I was leaving this building, per the official report, there were 4 persons in critical condition, and there was 1 person on a ventilator. Between then and yesterday, we were told 5 persons had died. Per the information we have now, 6 persons are in ICU also, and another 2 on a ventilator. So I'm asking myself, is it that the 4 persons who were in ICU over the weekend, did they die? What happened? Or did somebody simply move from being mildly ill and just died? Some of these things you just want answers to enforce, to inform what the trend is. But as things stand now, it's good. We are trying to improve our testing. Sometimes leaves questions to be answered. Yesterday, for instance, at the press conference, when our own Kojajiman raised the issue of the discrepancy in the Bolga numbers, let's be honest, the response of Dr. Kumar Bwaji, in all sincerity, was not the best. Let me be honest with you. And sometimes the delays lead people to raise all kinds of questions, which might not be necessary, because, again, like I said, we all admit this is a fantastic effort that has been put in by the government, by the Ghana Health Service, by all the parties involved. Everybody is working at optimum to make sure this works. So with regards to the transparency of numbers, it is important that we constantly get this right, so that we have the confidence and the buy-in of the general populace. What is the most important aspect of this now? We are hoping for some more positive results from the RDT angles, because that then means that we can improve our turnaround time on tests, because the RDTs, as we've been told, for the ones that the KNUST and INCAS have put together, but 10 minutes you can get a result. That is if it is done. We have not yet been told when production can be scaled up once they get validation done and how it will be made available and whatnot. But at least 10 minutes should be more than enough time to let us know that, okay, Frema went for a test negative, so Frema went home. That is it. As compared to Frema or Godfrey got positive and has been running around for a month, but nobody is calling Godfrey to tell Godfrey anything. That is the one hole in our strategy at the moment that we need to fix, because once, touch wood, we move from these mild cases that we have and all the asymptomatic cases who are running around, and we start moving into the murky waters of a lot more moderately ill, critically ill persons. That is when you have the health system getting swamped. That is when health professionals start getting worried. Final point for me on this, the PPE situation. For the past 3 weeks, I have lost count of the number of donation stories we have done on PPEs.
Quite a lot.
And the number of PPEs that have been bought and distributed across the board.
The ones we are producing.
But we still, on a daily basis, get reports from all kinds of health outposts who say we don't have the PPEs. We've been told that now they are considering doing this with the Ghana Medical Association so that they are able to point out which places need, because they were doing this in collaborating with national security for obvious reasons. But they need to find a way of improving the PPE setup. We cannot have this huge number of PPEs in the system, and constantly we get complaints of we don't have PPEs. I struggle to understand that particular line of our strategy. It's something that we need to deal with. But all in all, I would say that from at the moment, we can look at our numbers, not smile, but in proper hope.
Right, so Salom, we keep taking samples, we are testing people, but we are not able to get, the results quite early to people. So what is the point, just collecting people, that is, if they turn out to be positive? Should we begin to look at clearing the backlog, before we go into maybe another phase of testing?
We need to even conduct an audit into the backlog itself. We've been hearing backlogs for the past 2 weeks, and every time results come, we are told it is a backlog. What is the definition of a backlog? Does it mean that if I took samples 3 days ago or 2 days ago, that qualifies to be called a backlog? Because since we were told that we had a backlog of 18,000 people, we've had more than 30,000 tests conducted and results given in terms of the positives. But we are still being told that we have backlogs. So what is the definition of the backlog? We need to clearly understand what that backlog means. And if for nothing at all, I think the centers or the labs should be working faster now, because there are now a number of them. Yesterday we heard on the news that samples from the upper regions don't have to be brought to Kumasi, because there's now a lab at Tamale. So now, and I hear yesterday the UHAS, University of Health and Allied Sciences Laboratory, also started work. And the number of labs, the veterinary service lab is also doing some tests. So now we have not less than 6. Not less than 6, it could be more. So you have the UHAS lab, we have the Tamale reference lab, we have the veterinary service lab, we have the KCCR, we have the Kolubu reference lab, and we have Noguchi. So if we have all these labs, about 6 of them working, and the turnaround time is still as we've had it in the last few days, then I wonder what job they are doing. Indeed, some of the labs do not have the capacity as Noguchi and KCCR, etc. They should leave Noguchi and KCCR to do the big chunk of work. That is to be expected. But what happens to the tests they do? Because we are told that within 24 hours you should have a result. So why are we not fed results after every 24 hours? Is it a validation process? Is it the reporting? What really is it? We need to get that properly cleared for us. Coming back to, so that's important. You take a test, it takes weeks. And the psychological effect of that alone, having to wait for that long, it's even more dangerous than the COVID itself. Because your mind plays a lot of
Could I
games
be
with
positive?
you.
Could I be negative?
And one of the guests on Point of View the last time, the immunologist, said that one of the best things you can do to yourself is to have a good mindset. It's the best
to boost your immune system.
The best booster of the immune system. Yes, the immunopathologist. The best booster of the immune system is to have
it's a mindset,
a good mindset, and that is true. Because sometimes if you are told that you are even going to test for this, your mind plays games with you.
You can be sick before the test.
You don't have to take people through that. That is, it's for a reason why when people are going for certain tests, they meet counselors. They are cancelled, like HIV, etc. They are cancelled before the results come, or even before they undertake the test, because of these psychological things. Now you take samples for weeks, and you don't even inform the people. And I understand, or I hear what they are doing is because of the numbers. They only contact you if it is positive. If that is true,
that should be communicated clearly.
Then we need to know, so that if for a week or two I'm not contacted, I know that I'm negative. And again, what was the point in taking my samples 2 weeks earlier and not communicating with me or not telling me what the result is? Because it's not as if when you take my sample, then I'm immune or I've been vaccinated. No. You could take my sample right now, I could step out of the door, meet somebody with COVID, and something could happen, I could get infected. My results wouldn't have even reached the lab. We need to clear that. So it appears that they just want the numbers for policy reasons. But the people themselves whose samples are taking, not much is being done about them in terms of their psychological well-being. It's very important, and if the people are listening, the people must be contacted. You can text them that you took, your sample was taken on this date. The date is important. On this date at this place, so that if you are sent a wrong result, you will know your sample was taken on this date at this venue, and your test is negative. So that's fine. But if the person tests positive because of counseling purposes, you want to go a bit deeper, you can call and talk to the person, prepare the person's mind properly. That is what we should be doing. You don't take a test and people will be waiting for you forever and you don't come. It is not correct. Going back to the Ghana figures, an interesting thing I'm seeing is it appears a lot of the change in numbers we are seeing are coming from the general surveillance. And general surveillance, simply means people who walk to the hospital, people who have symptoms and so report to the hospital, are taken to the hospital. The enhanced testing is where the people go into the testers, or the health officials go into the population to trace and that kind of thing. We have huge figures. Doing that? I should think so, because they are doing contact tracing, etc. So if that will come under the enhanced tracing, enhanced contact tracing, that's fine. But if you look at the numbers, it appears a lot of the shifts, are coming from the general surveillance side of things. So you have 188 people who have recovered or been discharged, recovered and discharged, 188, and that actually constitutes our entire recovery numbers. So 188. When you look at the mandatory quarantine people, we've not really seen much from there. Enhanced testing, 0. When you go to critical or moderately ill people, you have 6, and all those 6 come from the general surveillance, 0, for the rest of the columns or the sections. And so we have a total number of 6 people in critical or moderately ill conditions, and all these 6 are from the general surveillance. Now let's look at the number of deaths. Ghana has recorded 16 deaths from COVID-19, and all these 16 deaths have come from numbers from the general surveillance. Nobody in the mandatory quarantine, nobody from enhanced quarantine, nobody in those areas have died. All the people we've received, all the figures we've received in terms of deaths have been from the general surveillance. The point, in my view, here is that there's a case, or there's something to be made for early reporting. The people who were mandatorily quarantined, a lot of them were not showing symptoms at the time they were quarantined, which means that and they were quarantined and tested and found positive, which means that in their case it was reported early. So maybe the treatment started early, so we've not seen much. All we are being told is that they are well and responding to treatment, either at facilities or at home. So it means things are picking up. Enhanced contact tracing, they went to them, they didn't wait for them to come to them, so that doesn't constitute general surveillance. It also means that when you report early, you can be treated and you'll be fine generally, which should also make the case for early results. Because if somebody tests and it takes a long time for the results to come, at what point that a person starts taking treatment?
Exactly.
Because the symptoms of the COVID generally may look like other symptoms. You have headache, you cough, you do that and that and that. Other sicknesses apart from COVID-19, manifest the same symptoms. So the point, we can't emphasize enough the importance of, the quick turnaround time for the results. Very, very important. I don't know what is causing it. I don't know if the talk about the RDTs will improve it or not. But the RDTs is great, but it also has its sides.
We'll be coming to talk about the RDTs, but you're still watching or listening to our special coverage on COVID-19. Let's take a quick break, and when we come back, we'll continue our discussion. Don't forget, you can also join us via our WhatsApp line 0550585832. We'll be right back.
Hello to the youth out there. My name is Mahamudu Bawumia, Vice President of the Republic. I would like to talk to you about the coronavirus pandemic that we are dealing with at the moment. It is a virus that has infected over 1.7 million people worldwide, and over 107,000 people have died from it. It is a virus that is transmitted either through touching somebody, shaking their hands, that they can transmit the virus if they are positive, or through sneezing, coughing, that can bring out droplets, which can touch you. So this is how it is generally transmitted. And because of that, we have the science telling us that we should try and maintain distances between people, 1 meter to 2 meters of distances, so that the droplets will not be able to travel very far. It is therefore very important that we follow the instructions that have been given to all of us. Minimize or don't shake anybody's hands.
You're still live on our special coverage on COVID-19. My name is Frema Dunyame. My guests in the studio, Salom Adonu and Godfred Akutu Wapo. Now, quickly, let's move on to some testing issues and some welcoming news coming in. So the Kwame Nkrumah University of Science and Technology and Incas Diagnostics, a diagnostic company in Kumasi, have created a rapid diagnostic test, that is the RDT kit, to help test for the novel coronavirus. So according to KNUST, the creation of the test kit is in line with Ghana's objectives in the fight against the coronavirus. So the device, likened to the homemade kit used in testing glucose or pregnancy, only needs a finger prick drop of blood from the individual and detects 2 different types of antibodies produced by the body to fight off the COVID-19 infection about 7 days after the infection. So the team lead and provost of the College of Health Science at KNUST, Professor Edu Sakode, has been explaining how the test kit will work. So let's hear him.
When the lockdown came, one of the issues was that so that we could test as many people as possible. And a lot of samples came through to Noguchi and KCCR as well. Okay. And the testing was delayed. Okay. We've said that when you test somebody, you need to be able to get results and act on the results immediately in real time. But if results are going to come back late, okay, it may delay They'll also be delayed, and which will mean that you may not want to put in place any measures you wanted to. Okay, so this is one place that this particular rapid test, which, like you read from the piece, takes 15 to 20 minutes to do. Okay, we'll be able to tell health authorities and everybody in real time what the test result is, so they can also act on it immediately. So the FDA is going to do some work on this to make sure that it works, it is fit for purpose, okay, before it can be used in Ghana here. Okay. Importantly for us, the FDA works with developers as well. So if there are any issues with what you've brought, okay, the FDA will work with you through those, so that the process is refined. There are 3 different rapid test kits that we've developed. Okay, 2 of them, FDA is having a look at them now. Next week, they'll have the 3rd one. Okay, they are all from different antigens. Okay, so there are 3 of these we are going to send to FDA for them to work on it, so we know how each of them performs.
Right. They say necessity is the mother of all inventions, and so we need to be very innovative at this time. Godfred, some welcoming news. But how would this help, in our testing and everything we've been talking about coronavirus?
Well, it's what the world has been chasing. Increased capacity for testing. The only way to do this, we know that, for instance, in the South Korea equation, they developed the test really, really early. By the 2nd week, Salom, I think, of the global pandemic, they had developed their own and rushed it through. Now, not all of it was accurate. The Chinese also developed theirs. Some of it had issues, but at least they went through it. Everybody has been looking to find a way of doing the RDT test in a way that you can rely on.
Yeah.
And that has been the big debate, the efficacy of this. Now, the cost is also another matter, because whoever creates it gets to sell it. So, for instance, the South Korean one, if they are bringing it to Ghana, it will come at a certain cost, because it's not owned by the state. A company developed it. They will sell it to you at a certain price. Can you afford it? How many can you afford to buy? So, cost was also a crucial consideration. Typical example, if you look at the one that the British put out last week, for instance, it was going to cost you £116 to get one of those test kits and get tested if you did the online application for it. And so it was important that African countries also found their own low cost methods of doing this RDT test, because as circumstances we have loudly shared with the world are different. That is why we're not doing what the West is doing. They say don't copy blindly. So we decided not to copy blindly. So last week, early in the week, everybody was hailing Senegal for what it had done. Now everybody's talking about Ghana for what we have done. A lot of other African countries are pushing to develop their own RDTs. If you're lucky to find you have the resources and the funding comes, because funding is key. And somebody paid for this. And we've been able to get to the point where we know that at least it will be done it will be sold at a low cost if it does come to that. The Senegal one, they were saying, was going to cost less than $1. We've not been told how much the Ghana one will cost, but certain things tell me it will be in the same price range, because I see one of the major backers in the Senegal project being one of the major backers in the Ghana project as well. So very likely that the two will go in tandem. So it's a game changer for us, and as we are discussed in the previous segment, due to the difficulties we are having with our turnaround time, and we had the good team lead, Professor Adusa Akodia, also make reference to this. If we are able to determine the outcome of a test within 20 minutes, it simply makes the clinical and preventive care faster and more efficient for everybody. We are then able to slow down the disease properly as we want to, and then everybody can go about their own business. So for us now, we are at the point of validation. We are waiting to hear from the FDA. We don't know what their validation process is. If you look at the literature that is available on this, basically what they say, I don't know if our process is the same. Basically, other labs must test this and tell you that this works. So it is not just up to Ghana's FDA. Ghana's FDA must make sure that other labs across the world also say, well, this thing works, and it works the way you say, because for all you know, other countries might come and purchase this from here.
Of course.
So if it is not passed fit by those countries, they cannot use it as well. And that is why, for instance, you would recall certain countries bought a batch of RDTs from China and ended up sending all of it back because they tested it and realized it was a bad batch. the UK also tried this some time ago, where they said they were going to purchase 3.5 million quantity here, not worth, not money, quantity worth of pieces of RDT, simply to test and make sure that it actually works. And this was about 3 or so weeks ago, before they finally got to the decision last week to start their own RDT. So the RDT is a big move in the COVID fight for all the parties involved. Once the FDA gives us a response, we then hope that at least we can move to production, which is another key point. People must recognize that the fact that it's been done by KNUST doesn't mean that when you walk in the following day, it's available. Somebody has to go and make it in large quantities, bring you 40, 50,000 pieces in a day, give it to you and say, work with it. That is also a significant process. And it looks like our state is very interested. If you look at the way it has put this out there, it's significant, and it changes the game for us. Let's hope we are able to see it through at this point, and it changes the game for us.
Salam, your thoughts on recreating RDTs locally?
I think it's great. We've called for it. I think it will help the testing, so you see the result yourself in 10 minutes, thereabout, 20 minutes or less. So it's great. It's fast. It's good. However, the RDT, though we've called for it, and so the scientists have gone to work and have produced, that we need to be a bit cautious about it. The same way when you have it for malaria and pregnancy tests, sometimes you have what we call the false positive. The false positive could also occur here. So what happens is that there are two types. One will use the nasal swab, and another uses the blood. I'm not sure which one.
So he spoke about the blood because he said
the blood looks out for the antibodies. What happens is when you have an infection, the body's own defense mechanism gets into action. That is why it's important to boost your immune system. So the body's defense mechanism gets into action. So in pedestrian language, we call them the body soldiers. The body produces or unleashes its soldiers onto that foreign body, that pathogen, to defeat it and kill it. The fact that your system is warring against a foreign particle, that is why fever, we say, is not symptomatic of a particular disease. It could be a symptom of many things. So what the blood one does is that it tries to identify antibodies. So antibodies of this coronavirus in your blood. The thing there, however, is that we have a number of coronaviruses responsible for other things. This is novel. This is the SARS-CoV-2, which causes the COVID-19. So are these RDTs able to distinguish and pick the appropriate coronavirus? So you could test positive, but it may not be positive for COVID-19. It may be positive for coronavirus, something else. But of course, we hope we don't have a lot of them in the system. That is the only issue with it. But apart from that, I think it is great. So what I've described is what we call the specificity, looking out for that antibody and then picking it out. That is what gives it its quality. And a lot of them that have been tested elsewhere shows just about 50% in terms of specificity, and that makes it a bit tricky. But as I've stated earlier, and as I've said many times before, it is a great step. It is good that we have reached here. Our scientists have done that. It will at least afford us some effort and opportunity in testing ourselves to know what the situation is before we even raise alarm. For example, if you test yourself, it tells you no, but you are feeling the symptoms. You test again, maybe you will see it. But generally, it is a great thing, but we don't have to use it going to bed that it is 100%. It is good, but you can't compare that to the PCR, the polymerase chain reaction test, the one Noguchi and Co do. That takes a long time to do. That is more expensive, but that is a bit more accurate in terms of specificity, reliability, and everything, and validity than the RDT. So the RDT is good, but the PCR is better. But for the sake of time, etc., going for the RDT is not bad.
So whilst we are advocating for RDTs, and should we not also be looking at how we're going to match up in other areas? For instance, Godfrey just mentioned the case of PPEs. So if the RDTs are out, then are people, if we validate, we know this is going to work for us. People are going to be using them in huge numbers. Now, if we begin to record positive cases at a very faster rate, are we prepared, to deal with these cases, our health system and everything?
Okay, so I think what will happen is a lot of the negatives will be cut out. So for example, if you have 10,000 samples and you have only 50 positives, 9,050 were negative. A lot of these will be cut out using the RDTs. So you have just 50 going to the test, whose test may want to be validated again using the PCR.
We've done a lot of testing already, and we have a lot of people out there who do not know their status.
Exactly. So that will reduce the pressure on the big labs, the UHAS, the Noguchi, the veterinary, the KCCRs. So they focus on real cases just to validate what the PCR, what the rapid diagnosis test has done. About PPEs, I wonder if we'll ever get to a place where we will have adequate PPEs, because the US of all places is also complaining of inadequacy in terms of PPEs. Fortunately for us, I was watching Umar Sanda, it was yesterday on Citi Newsroom at one of the manufacturing companies producing the PPEs in large quantities. I don't know if they are the one-off PPEs or the ones they can reuse, whatever they are. It is great that we are developing local capacity to produce this, and this is what we've always called for. What we have to do is to ensure that we boost their capacity so they can meet the demands. And also, people who get the PPE and decide to hoard them or use them for certain parochial interests like politics, etc., should stop. We hear that some of the politicians have them and they want to send them to hospitals in their constituency. That's great because they are hospitals, but there is the epicenter.
Exactly.
People you have instances where a lot more doctors and nurses are getting infected. At the last count, about 13 doctors have been infected. How many doctors do we even have in Ghana? And look at the doctor-to-patient ratio.
Exactly.
If you take out 13 of these people, that's a lot of people left without doctors. And nurses, we are not even sure the number. So PPEs, yes, great. I think some effort is being done. But though we commend the effort, a lot more needs to be done to raise the numbers so that we will not have health professionals all over the place complaining of PPEs. That is their weapon. If you send people to the battlefield, put them at the war front, and you don't give them weapons, what are you expecting them to do? They will be killed and they will come back. And we don't want our health professionals, who are one of the, or some of the most intelligent people we've had when we're in class. The guys who went to study medicine were some of the best, etc. We don't want these good human resources we have to lose their lives to this disease. Now that would be a tragedy. So whatever it takes to increase production of the PPEs, let's do it.
Right, so let me quickly take some of the messages that we have. So Louise from Lubo says, we in the border, at the border at Western Region, Cote d'Ivoire, that's Lubo, are already experiencing a total lockdown due to the fact that our borders have been closed. So my question is, what is the government doing about places where economic activities depend solely on the opening of borders? Because it seems we have been neglected and people are really suffering here. Now, okay, so Johnson Williams from Dry and Kwanta says, how can you say wearing a face mask is compulsory without making it available? There is a missing link. One important characteristic of a good data is timeliness, which means data should be collected in a timely manner, example, daily, weekly, monthly, in order to effectively track changes. Unfortunately, the data on confirmed COVID-19 cases, GHS has been presenting to Ghanaians lack this quality timeliness. So now the big question is, what is the trend of Ghana COVID-19? I mean, how does the curve look like? If there is no update on GHS website, does it mean we have not recorded a single case of COVID-19? GHS shouldn't try to throw that into Ghanaians' eyes by drawing any curve on their website. This is Fosti from Takwa.
That's a very good point. Very,
exactly.
very good point.
Another one
because just before you come in.
Yeah, so let me just add this
Okay,
one, then we
okay.
just take them. So first one again is asking, please, I would like to know if the COVID-19 cases from Kaswa are recorded against Greater Accra region or Central region figures. I'm asking this because initially Central region case count was 0, but we had cases from Kaswa then, right? So this is coming from Fosti from Takwa again.
Before Salon comes in,
Yeah.
the issue of the face mask, the local production.
Yeah.
And it's a question a lot of people have asked, that at least are you going to make it available to us, the correct ones, to purchase, maybe at a reduced price? Because
But I've been putting out what we should be looking out for, the 3-layer one.
yeah, I know. I'm just
Yeah.
saying, what is the people are making those at home or what is the capacity of people to make those as compared to the mass production? Now, if you take your mind back to the April 7th or 6th press conference, when this announcement was first made by the health minister, Mr. Kukwajima Menu, the announcement he made on that day said that they had engaged 5 companies to make 3.5 and that the first batch would be taken within 10 days. That was on the 7th. Would be available for distribution
to medical people, to the public.
We don't know where. But it will be
I think that
interesting.
when he was speaking against the health workers' issues because of the complaint of they not having
Let
the
me read the
PPE.
quote.
Please
Let
do.
me read the quote.
Yes, please read.
The 5 companies that have been selected to produce the nose mask will start production by the end of this week, which was the 7th. And we expect to take delivery of 3.6 million nose masks within 10 days. That was his quote.
So okay, great one. So I think it will be important now to do a follow-up.
Yes,
Find out
I'm just asking.
if those 3.5 or 3.6 million nose face masks have been delivered, where they have been to. I have a feeling maybe that will go to the health sector because at the time
3.6 million face masks is a lot of face masks, even for the public sector.
But most of these people
Yes,
are
but
being
for the health sector,
being
single
disposed
use.
of. Yeah.
Even for the health
use.
sector.
Yeah.
The ones that are producing are not just single use.
Because don't forget,
Okay.
at that time, wearing of nose masks was not compulsory.
hadn't become topical.
Exactly.
Certainly, but it was part of. It was
Safety measures.
it was in anticipation of times like these. So, you see, 3.6 million is a lot.
It's a lot.
It's remember, you can't just
know.
get rid of 3.6 million pieces of face
Yeah.
mask in the hospital, just like that. So all I'm asking is, perhaps it might be time to make some of these available, considering that
First of all, we
you
check
certain
if they have been
projections.
delivered, they have
Certainly.
been produced.
Yeah.
Then we see how the distribution has been.
Yes.
Yeah. But just one quick
You see,
one.
because again, let me just, before Salam comes in,
Yeah.
the quotes are clear. It is for this reason the government is actively engaged with local manufacturing companies to assist them in the domestic production of PPEs.
Yeah.
And I am encouraged by the response from the Ghanaian private sector. Domestic production of face masks, head covers, surgical scrubs, and gowns will commence from Tuesday. For example, 3,600,000 face masks will be produced domestically with an output of 150,000 per day. 150,000 per day.
Yeah. So we need to know if they are producing this
of course,
capacity.
Health sector covered, but
Yeah.
a lot of that should overflow into the
But
public space.
quickly before we go, Godfrey, I've been thinking, can we have some kind of like maybe GS, Ministry of Health, whoever is in charge, liaising with telcos to get a short code? I mean, find a way, because when you're going to do the test, your details are collected, so they have your phone number. Is it so difficult to get the telcos to maybe work with, to send, for instance, those who are negative, just to let them know that you are negative, so just have a clear mind and be safe.
I'll leave this for Salom.
Yes, we need to get innovative. It's maybe nobody has thought about it. Maybe they think it is not just sending a text to somebody. It's not.
But if you're negative, just inform the person.
A text message. But again, would that have to be centralized? So if I did a test at KCCR, where should the testing center? Where should the texting center be? How should it be? We need to work out those modalities. Who does that? Is it a health authority? Is it the testing center or the telco? We need to understand how that works. And if that is clear, that's fine. But even without that, I don't think it's too much work.
Yeah.
Basic, texting codes. You could do it and put your name there. So maybe you did a test at KCCR, or maybe make it GHS.
Yeah.
But give a number of the testing center saying GHS caption,
Yeah.
so that when they text you, GHS comes on it, or it could be the Gucci or KCCR. You did it. Your sample was taken or at the Braka Polyclinic. The sample was taken on this day by these people, by this office. The test turned out negative. You are fine. You don't need to talk plenty.
Yeah.
If it is positive, you think because of the nature of it, you have to call the people.
Exactly.
That's a different matter.
Yeah.
But again, to leave the people to just figure things out for themselves, I think it's not appropriate. You know, and sometimes a lot of the questions some of the questions that are asked at these places, at the press conferences, sometimes the answers don't come. Maybe because the answers are not there. Like Alfred is saying, some of the answers given by the Ghana Health Service boss actually could be better. So for example, why don't we have daily reports of infected cases?
Exactly.
Because we are told that
asking.
thousands of tests are conducted every day. And out of those tests, if you recorded 0 for positive, let us know. If you recorded 5, let us know. Whatever you recorded, let us know on a daily basis. It helps us. At this stage, we are a month and 2 weeks or so into the COVID-19 era or fight. To date, we don't have an idea of what our basic reproduction numbers, or what they call the R0, which tells you how many people somebody with the infection could infect. We need to understand all that. Initially, when the disease started, the WHO told us it was 2.25 or 2.5 or so. Some countries which are easing their restrictions, etc., are recording the basic reproductive number below 1, and if it's below 1, that is great. You know, we need to know where we stand in that. We don't. Nobody tells us anything. And when you ask, it appears. I mean, nobody even answers the question. Nobody picks the question up. Nobody answers it.
And if we are getting reinfections,
what if we're having reinfections? And even if the people who have been infected, the statistics we have, the people, what has happened to their immediate families? Whether their immediate families, to some extent, have been infected. For example, the gentleman Sanders spoke to at Tema, the one who appeared at the information ministry to talk to people about Fred. His family was fine, but before that he was with his family. And I think the more we know some of these things, it will help us appreciate the disease better, and a lot of the way we see people with the disease and how we behave may change. The disease is real, but people must know how the infection is, whether it's 100% infection, about 10%, 20%. We should have an idea. I'm also interested to know who the youngest infected person has been. Of course, we've seen some 84, 88-year-olds die from it, and we understand they had pre-existing conditions. Those people referred to as
with underlying health conditions.
Underlying health conditions. We need to know. I'm interested to know who the youngest person, for example, is.
Especially because earlier
and that was a myth. It only affects elderly people. That's a myth. I think that the only thing there is that people with stronger health, immunity or immune systems are able to are stronger. They don't have, a lot of them don't have pre-existing conditions, so that is a bit easier on them. So we need to have all this information, and the more we have those, the more we can understand things better, and analysis could be better.
Right, so we'll keep following up and be updating you on how the trends move. So let me say a big thank you, Salom and Godfred, for your time this afternoon, and thank you too for watching and listening to us, and to those who also sent in their messages and comments. Thank you very much. Once again, this has been our special coverage on COVID-19. My name is Fremedu Nyami. We'll see you again tomorrow. Take care.